Hello and welcome to everyone participating online. Today we are happy to have the CTNH Webinar 2024, and we have a panel of very esteemed and established speakers with us, and as shown on the screen there. So this whole webinar will take about 2 hours, right? I'll start off with a welcome and introduction note, followed by the 4 speakers. But before we proceed, let me just share with you some housekeeping rules. As with all scientific discourse, we do welcome questions. So type your questions using the question and answer feature. And what we will do is compile the questions and answer them in a forum discussion manner as the last activity of today's webinar. And for those of you who stay on until the end of the webinar, we will give you a certificate of attendance because you can then collect your CPD points as shown. If you are an MMA member, this webinar entitles you to 1 CPD point. And if you are a dietitian or a nutritionist, this webinar entitles you to 4 CPD points. Right? So I'll first introduce myself. I am Dr. Lee Cheng Lee, a dietitian by training and also a lecturer and the head of the Glycemic Index Laboratory at the IMU University in Malaysia. And with me today are 4 very established speakers, well known in their field, who will then share their insights on diabetes remission, in particular, their thoughts on how this can take place in Asia. We will start off with a session by Professor Michael Dean, who will provide an update on new guidelines and the rollout of the diabetes remission programs globally. And then he will be followed by Professor Mike Trenell, who will be talking about the digital delivery for diabetes remission at scale. And then the third speaker of the day will be Professor Anthony Leeds, who will look at evidence for benefit in other comorbidities in diabetes remission programs. And last but not least will be Professor Winnie Chi, who will then talk about dietary aspects, including the use of liquid diet for weight loss and remission, with a particular focus among Malaysians, right? So without further ado, I will first introduce the first speaker, Professor Michael Lean, who is affiliated with the University of Glasgow, UK. He has an extensive portfolio, many awards, more than 550 published papers, including the landmark remission trial, the diabetes remission clinical trial, or the direct trial. Okay, Professor Michael Dean, the stage is all yours. Okay. You are muted, Prof. Yes.
There we go. Thank you very much indeed. It's difficult to mute me, so I'm now unmuted. This is a lovely opportunity to tell you a little bit about what's going on in the UK. I guess this story about remission of diabetes is really very new still. People had thought about it, wondered if it was possible. We showed this is absolutely possible, and I'll run through that quickly for you. And I'll also be able to give you some idea as to what's going on in the UK now. I'll share my slides and get cracking. Here we go.
Thank you.
What we need to do now is move it up. Come on, get up there. There we are. That should be visible to everybody.
Yes, very clear.
And I'm hoping to get through this in 25 minutes. I do have some disclosures, and they're all pretty standard, obvious ones. They sit there. The background, I guess you all know this. Type 2 diabetes is now one of the biggest, most frequent, commonest disabling and killing diseases in the world. It shortens lives on average by about 5 or 6 years, and that hasn't changed over the last 40 years since I started working in clinical medicine. Despite all our new medications, it's still shortening lives with horrible complications. And we've also learned, and it's very obvious, that this disease only occurs when populations gain weight. So through most of our evolution and history, there was no type 2 diabetes because people did not become overweight. And we've learned, and I think the direct trial has cemented this, is that not just gaining weight, but it's gaining weight and putting fat into what we call ectopic sites, in intracellular sites within vital organs. And that includes the intra-abdominal fat. So and that is largely genetically determined. So people either do or don't put their extra fat into the abdomen, into ectopic sites. But that's the background. We know just that it's not becoming obese. It doesn't require a body mass index of 29 or 28, 27, 30. This is a disease process that starts at a very low level. And we're seeing half the diabetes in the world with a body mass index below about 26 or 27. So, and these are figures from North America, where even in North America, half of all type 2 diabetes is in people with a body mass index below 30. The risk increasing rapidly and dramatically with a BMI of 23, 24, 25. It's a disease process, it doesn't depend on reaching a very high BMI. And we've known for many years now that losing weight with the help of dietitians, achievable weight losses, and this is a North American study, similar studies in Europe and in China, which have shown that losing weight of the order of 6 or 7 kilograms on the left here in the blue line, with dietary advice, mainly dietary, physical activity doesn't add very much to this, and maintain it quite well, not very well, for 4 years, with 4 kilograms off at 4 years. That is enough on the right-hand side of the panel to remove, beg your pardon, more than half the type 2 diabetes. So preventing type 2 diabetes in people known to be at risk, they have prediabetes, is achievable by dietitians and a little hard work by people who don't want to have diabetes. The process can be arrested. And so we asked the question, can we do this with people who already have diabetes? The prevention has been replicated in many countries, and it's absolutely understood now that weight loss is the dominant factor, but having a moderate fat, or low saturated fat, rich in fiber, whole grains, and of course fruit and vegetables. The Mediterranean style diet, it seems to be the best background for that. And there are many Mediterranean style diets. I don't think I need to jump through that. The guidelines that we have now say basically, and they have for many, many years, always said, advise healthy diet and lifestyle. And I'll draw your attention to 2 points there. Firstly, the word healthy. This is a marketing term. And it has no health meaning at all. The foods sold in supermarkets are often labelled healthy. They have no difference, they have no advantage, and we did a study looking at that in supermarkets in the UK, the same the world over. The word healthy is a marketing term which does not have any impact on consumers or consumer behaviour. And the next thing is, there you go, marketing term. The next thing is the full stop at the end, because the guidelines just say that, and often no more. They then generally suggest weight loss if people are obese, and that is interpreted as BMI over 30. So I've already told you that's wrong. And then they go on to talk about 30 or 40 different drugs which may be available in different countries, which are designed to cover up the diabetes by lowering the blood glucose, but leaving the disease process. They don't cause weight loss, at least most of them don't cause sufficient weight loss to do that, with the exception of the new GLP-1 agonists. To look into this in more detail, many years ago, we did a study in Scotland which offered people, well, it took people who had intentionally lost weight with the help of dietitians, and our dietitians were very good in Scotland at that time, to see whether if they lost weight, did they live longer? And on the left-hand side of this panel, you can see people who did not lose weight in this study, they died around 7 years younger than people, beg your pardon, than people who did not have diabetes. So people who did not have diabetes lived 7 years longer. If they lost weight with the help of our dietitians, they actually lived longer. And at the very end here, 14 kilograms, people who lost 14 kilograms in the first year of treatment. So this is hard work with the help of dietitians. Not many did it, but those people lived just as long as people who never had diabetes. In other words, losing 14 kilograms or 15 kilograms was enough to eliminate the mortality from that disease. This has been repeated in North America by David Williamson and several other studies, but it would be good to repeat this elsewhere. So that was the background before we designed the direct trial, which was funded by Diabetes UK. That's a patient organisation. It's a charity which brings together people living with diabetes and the doctors and researchers who are trying to help them. So it speaks on behalf of people with diabetes. They were surveyed and asked, what do you want us to do in research? And they said, as number one priority, we would like to find a cure or a remission for type 2 diabetes. And already we were beginning to use the word remission as a concept. And so this was the study. And the important things about DIRECT were that it was carried out entirely in primary care, routine NHS primary care, which means the patients did not come into hospital. They didn't even see a doctor in most cases. They saw the practice nurse or a dietitian if there was one available, and that was who delivered the program. They were very typical patients from the UK, and we accepted them up to 6 years after the diagnosis. That isn't because 7 or 8 or 10 years it doesn't work. It means it was purely because we wanted to make sure that we had patients who would survive for long enough to be able to conduct the study. It was a research requirement, not a clinical requirement. And in that cohort, the mean age was 54. And they'd had diabetes for, on average, about 3 years. Hemoglobin A1C on treatment was 55, so they were quite well controlled, and the body mass index 35 kilograms per meter squared. So very typical patients who are being seen all the time in primary care where diabetes is managed in the UK. We then, on day one, we said, we're going to ask you to stop your anti-diabetes medication. All of it, and your antihypertensive and diuretic medications, all of them. And the reason for that was because on day one, they started what we call total diet replacement. This is a diet program using a formula diet, giving only 830 calories a day. With that, they will be in negative energy balance and they will lose weight quite rapidly. If they were to continue with their medication, there was a risk of hypoglycemia or of postural hypotension. I think the blood pressure reduction, and I'll show you the results here, is very profound when people lose weight. This is a very potent treatment for hypertension. They continued with that diet program for 12 weeks. We allowed them weekends off or even holidays, so up to a total of 20 weeks with 12 weeks exposure to the diet program, and then introduced meals, and I'll explain them one by one meal for a week or 2 weeks, and then the next meal, to try to get people used to eating foods, not formula foods, thereafter. And they went on then to long-term diet program for weight loss maintenance. So it's not so strict and has a great deal of flexibility. We allowed them to use one meal replacement a day if they wished. They didn't have to. Some did, some didn't. This is what the intervention actually looked like to the participants. They had workbooks describing each stage in the program. The formula diet came in packets. You make it up with either water or milk, and it comes to about 830 calories a day. It contains all the vitamins and minerals, so we know that it's safe. The food introduction, then, as I say, at that point, they were given step counters to try to increase their physical activity. And the data we obtained showed they did not. These people find it very difficult to increase physical activity. So it's not a good use of your time or energy asking them to take more exercise. They find it extremely difficult. And frankly, they can't, even when they're heavily coached as they were in this trial. The weight loss maintenance diet, we decided, and I think rightly, that people are most likely to adhere to a diet in the long term if these are using familiar foods, the same sort of foods as the rest of the family, and a traditional style diet rather than something unusual and restrictive. So we went for a diet program which was approximately half of the calories from carbohydrates, so not high, not low, about in the middle, which is normal for much of United Kingdom. 35% fat, 15% protein. And importantly, we offered them what we call relapse management. So if they were to regain 2 kilograms, we asked them to let us know, and we would then give them a short period, 2 to 4 weeks, back on the total diet replacement in order to get back on track. So they don't lose heart from regaining weight, because I think it's very demoralizing after all the hard work to lose weight, then to put the weight back on again. So that's what it looked like to the patients. I'm just showing here individual patient trajectories from another study. It was a pilot study of 91 patients, just to point out that usually when we present results, we give you a mean and standard deviation. And I've shown the mean line here in the green dotted line, which is this, the weight loss is in the initial phase, and then there's a gradual regain. But within that, there's a huge variation between individuals. And by and large, you can cut them down into some individuals who frankly did absolutely nothing. They said they were following the diet program. They weren't. They were absolutely not. They didn't lose weight. Some of them actually gained weight. And when we looked at what they actually said they were doing, most of them actually gave up the diet program. That's in the black lines within the first few days. These are the numbers of days on the program. Those who stayed apparently taking the program for the full 12 weeks in the study then came into, again, different results. There were some patients who did pretty much everything they were asked to do, who didn't cheat, who lost 15 kilograms or more, and some of them a lot more weight, as you can see, 10, 30, 20, 30, even 40 kilograms. And in the middle, some who partly adhered to the program. So people, even in our highly educated United Kingdom, don't actually do what they've been asked to do or what they say they do. That's worth bearing in mind. The results of DIRECT, I think everybody has seen these. We set a target to get better than 20% weight loss, 20% remissions, do beg your pardon. And what we actually found was 46% remissions. So these very typical, very ordinary patients, nearly half of them were free from diabetes, off medication, hemoglobin A1C below 48 millimoles per mole at 12 months. And that was way better than our intended target. And they had a mean weight loss of 10 kilograms. And very broadly, those who lost more than 10 kilograms had a very high chance of remission. Those who did not lose 10 kilograms, rather a low chance of remission. The control group, as you can see, did very poorly, only 4% lost weight and got remissions. At 2 years, we expected, because there was a certain amount of publicity around the results at 1 year, we expected the control group to have done better, but they didn't make the effort at that point. The intervention group, at that point, 36% were free from diabetes, so still way better than our 1 year target, with a mean weight loss of 8 kilograms. And that decline was entirely because of 15 individual participants who regained weight. And that was interesting because when they regained weight, we could see that they were individuals who had lost more than 10 kilograms, and then their weight went back up to closer than 10 kilograms from baseline. So it did seem that 10 kilograms was really the sort of hurdle with a good chance of remission. Putting those 2 years together, this figure, which was published by one of our dietitians, George Tom, shows that the remissions were very consistent if people were able to lose weight. Now, on the right-hand side, those who lost 15 kilograms, 86% were in remission at 1 year, 82% at 2 years. And you can see even for 10 to 15 kilograms, very high proportion remained in remission. In fact, it was actually higher, almost 80% were in remission for 2 years if they lost over 10 kilograms. This is a persistent result, which very much depends on maintaining that weight loss. We looked to see, people often ask me about non-responders to this study. And what we can see is that with 15 kilograms weight loss, only 14% failed to get a remission. And those 14% who failed to get a remission, most of them actually improved, but not quite to the point of remission. So they probably needed to lose more weight. They started with a body mass index of 35, and they remained, even after losing 15 kilograms, seriously obese. So probably they need to lose more weight. There were, however, about 3% who lost 15 kilograms and failed completely to see any improvement in their hemoglobin A1C. And those are sort of true non-responders to weight loss. When we looked in detail at those individuals, it turned out that several of them had been untruthful about how long they'd had diabetes. They'd had diabetes for many, many years, and it became difficult to reverse. There were 3 who gave past histories of recurrent abdominal pain, hospital admissions for abdominal pain, and one of them was actually diagnosed as having had chronic pancreatitis. So damage to the pancreas by pancreatitis, possibly secondary to gallstones, seems to be one of the reasons why some patients are unable to get a remission, even if they lose a lot of weight. And that was an interesting byline. So there you have it, 97% significant hemoglobin A1C reduction, and 86% no longer diabetic. My colleague Roy Taylor in Newcastle, some of you may know, carried out some studies with a subset of the direct trial and put them through some detailed imaging and kinetic studies. And what that showed was, firstly, that people with type 2 diabetes have very high liver fat. And I think we're probably beginning to understand that already, but we were able to put figures on that. And importantly, to show that when people lost weight and had remission of their disease, that's what we call responders in the blue column here, they lost that liver fat. It fell to normal in quite a short time. With the loss of liver fat, there was a fall in the VLDL export fat from the liver. And with that, there was a fall in the fat content of the pancreas. And so there's a sort of overall loss of this ectopic fat, which is built up in vital organs. Those who failed to get remission of their diabetes in the turquoise colors did not have the fall in liver fat, did not have the fall in VLDL or the fall in pancreatic fat. And interestingly, in the yellow columns, the people who had relapse at 2 years, not only did they regain their liver fat and their the pancreas fat, but you could see the increase in the export of fat from the liver at that time. So this is a very clear demonstration that the ectopic fat is driving this disease. And with that, there was this dramatic change in the morphology, the shape and consistency of the pancreas, which became normal, not overnight, not in 12 weeks, but over 2 years. It was a gradual recovery of the pancreas structure. And at the bottom there, you can see that as the pancreas filled out and became normal in volume, so the maximum insulin secretion capacity rose. Now, this is very new. This is very new because we were taught that when people have type 2 diabetes, they have a limit to the amount of pancreas of insulin that their pancreas can secrete, that effectively the beta cells have declined, and we were taught that they were dead. They're not dead. If patients are able to lose weight, get rid of that ectopic fat, their pancreas will start to make insulin again, and it returns not just a bit, but to normal, to completely normal at 2 years. It takes 2 years to get there. So there's a story. I mentioned the blood pressure fall, and this is really very important because we give many, many drugs to people for high blood pressure. They're effective. They're quite effective. Weight loss is much more effective for people who are overweight. And the fall in blood pressure in the white line here, down to a drop of 15 millimeters of mercury, is in people who were not previously on medication. And that would happen to the people on medication if we didn't stop it. In the green line is the people who stopped one drug for their blood pressure. And you can see that their blood pressures also fell throughout the total diet replacement period. And in the yellow line, the people who were on 2 or 3 medications for their blood pressure, which we stopped, their blood pressures did not increase because they were losing weight. And what we saw at the end of total diet replacement was blood pressures were all roughly 10 millimeters of mercury below baseline. Now, that's a huge effect, much higher than we can achieve with any medication for blood pressure reliably. But it's worth noting that the people who were on 2 or 3 medications for blood pressure did need to return onto one of their drugs after an average of about 6 or 7 weeks, 42 days. So the blood pressures we monitored, and we restored one medication to control the blood pressures if their blood pressures tended to rise. And that tended to happen once the weight loss was declining. These are people who were no longer adhering to the diet program fully. Big story about blood pressure. Subsequent to DIRECT, and we put on here 3 studies really. DIRECT trial, and we've looked at the percentage of remissions against the weight losses achieved in DIRECT. In a subsequent trial in Qatar, in using Arab and North African participants who are a bit younger, and also in the red dot, a study in South Asian, mainly Pakistani people living in Glasgow. And what we found was that the weight loss determined the amount of remissions. So remissions would reliably occur depending on how much weight people were able to lose. And that was important because it showed that South Asian people had exactly the same response to weight loss as people from European and North African Arab origins. There isn't a difference in the methods and the mechanisms behind their disease. And I'm going to fly through this very quickly. There have been several other studies which were essentially Me Too studies. I put at the top here the direct trial and Diadem 1, which is in Qatar, which both use the same protocol, same diet intervention essentially. And they got weight losses of 10 and 12 kilograms at 1 year with remissions of 46 and 61%. A better result in Qatar, but with a much higher remission rate in the control group because these were younger people with more recent disease. There were several other studies looking at low-carb diets, keto diets, and just so you can see the 1 year remission rates were nowhere near as good as those which we achieved using the total diet replacement and weight management approach. One study which is interesting is David Unwin's study, which is a primary care study in England. And his statistics were not very good in his initial publications. He got a 12.5% remission rate across his entire population at 2 years by giving advice for a low-carb diet. He didn't initially report weight losses, but when Roy Taylor went back with him and reanalyzed his data, they did indeed lose a lot of weight. So it was actually, again, down to weight loss, which he was managed to achieve with one of these low-carb diets. There's plenty of evidence to say there's no special advantage to that type of diet. It's just that was what he preferred to do. Following the publication of Direct, these are just some studies that I have been involved with, just to show you in principle what sort of results we're getting really around the world. In the South Asian study in Glasgow called Standby, we had 40% remissions from the same intervention as in Direct. In Retune, which was run by Roy Taylor in Newcastle, they had a remarkable 70% remissions. And these were individuals with type 2 diabetes with a body mass index of 23 to 27. So many of them not even in the overweight category, but with type 2 diabetes. And sure enough, they had fatty livers, fatty pancreas, and that fat disappeared with their weight loss. So they didn't need to lose so much weight as people who are more seriously obese. A direct trial in Australia, 56% remissions, and then a big observational study also in Australia, 40% remission. This is an intervention which absolutely works, and we don't really need to prove that it works again, but we are looking for different ways of delivering and different ways to maintain the weight loss and to look at longer-term results. The longer-term results in Direct, we can show you here at 5 years. And I think it's important to point out that at the end of the 2-year trial of Direct, we wrote to every participant to say, here are the results. Weight loss makes a massive difference. We gave the access to the weight loss program to the control patients through their primary care practices. And so many of them, the control patients, then went away and actually lost weight, and some of them got remissions. Well done. So this is no longer a randomized controlled trial, but we can see the legacy effects from the original trial in these results. And what we found was across the board, those who'd been in the intervention group had less than half the number of serious adverse events over 5 years. Those are the numbers there, 5 per 100 patient years compared to over 10 per 100 patient years. Highly significant. So the intervention kept people out of hospital, avoided serious events. We also looked at what we call diabetes-related clinical events in the intervention group only. Those who were free from these events, mainly infections and such like, were those who lost more weight from the baseline. And over the 5 years, those who had a lower BMI at year 5, those who had a lower hemoglobin A1C through the trial, years 2, 3, or 4, and those who had longer durations of remission. So long duration of remission helped to protect against diabetes-related clinical events and also serious adverse events. And you can see that on the panel on the right here, quality of life was hugely improved at year 1, year 2, year 3, and year 5 of this trial for the intervention patients. So they liked it, they felt better, and they had less health problems. We asked the question, many people asked the question, does it reduce the heart disease? Well, Direct was not big enough to do that by a long, long way. It was a if you like, a proof of concept study for 5 years in quite a small number. However, the Look Ahead trial in North America had over 4,000 participants for 10 years, and a big study in the south of England with 60,000 participants studied for 7 years. Both of those have shown that patients who achieved a remission, that's a hemoglobin A1C below 48, without medication, without glucose-lowering drugs, had fewer cardiovascular events, fewer kidney disease, and a lower mortality. So I think we can be reasonably confident that this is going to improve everything. Guidelines now say weight loss might be a good idea, and many of them are now suggesting that the type of approach used in direct was an advantage. They are clearly now beginning to listen to what the patients want, and I think one of the messages here is that in writing any guidelines, we must have input from the people living with diabetes. It's also what their doctors want. And I'm going to fly fast through this. I don't need to spend time here. The European Association for Study Diabetes has a nutrition study group which writes guidelines. And in that guideline, it has now said quite clearly that a direct type intervention is the preferred approach to get remissions. And it also points, and I'm just pointing this one point here, saying that we must draw a distinction between therapeutic diets, and there are several of them, low GI, low carb, DASH diets, which are very effective, but very restrictive and often expensive, and they're very difficult for long-term adherence. We have an alternative approach using traditional diets, and there are many of them, Mediterranean, Japanese, vegetarian diets, which may be less potent, but they don't have a high cost, in fact, often zero cost, and they're easy for people to follow, so perhaps better long-term adherence. I'm going to jump through that. Mike Tranel, I think, is going to say more about the program in England, which is using digital methods, which we have found to be very, very effective. And they're getting remission rates which are comparable with the direct across very large numbers. Now, I think it's 20,000 people are being put through a similar program across England. And in Scotland, every health board in the country is now using the direct program, the Counterweight Plus program, which was developed and used effectively, successfully in direct. And just finish off by saying we realize that not everybody wants or is able to access a formula diet in the way that we designed direct. We have an alternative in Scotland. We have something called the No Doubts diet. It's a little bit of a joke. It's very Scottish. It has porridge, which I have every morning. It has lentil soup, which is one of our favorite dishes, with bread and fruit, to give 830 calories or 850 for a weight loss induction diet, and then go on to maintenance by replacing one of those soup diets later in the day. And based on that, which is very popular and very effective, we designed a study for Nepal using, again, traditional foods, a dal bhat, with modest portions of rice and a dal, a lentil-based dal and vegetables. And I can just show you very, very briefly the bottom line here. Using that diet in Nepal, and this is not a high intensity intervention. We got 43% remissions of diabetes at week 12, and then week 24, 39%. Not very good maintenance at 12 months, but nearly a third of the patients were free from diabetes. And these are people who started off with a hemoglobin A1C mean of 6.8%. And on multiple medications. So this was a very striking result, and we're following that up with a much bigger randomized trial. So here are my conclusions. Type 2 diabetes is preventable, reversible by weight loss if you catch it early. And that means certainly within the first 10 years, best in the first 10 days or 10 weeks, certainly. So get it early, you have a much better chance, and get it while people are still a bit lighter. Although the most effective interventions use formula diets, there are other alternatives, and we're basically looking now at traditional diets as a way of making this more sustainable. So thank you very much indeed. I hope I've covered the ground adequately.
Thank you, Prof. Lin. It was really exciting listening to all of that. We now know diabetes remission is possible. There's the data is just so exciting, and I particularly like the legacy effect that weight loss and diabetes remission gives to our patients. So that's really good. Okay, now we're going to move on to the second speaker of the day. Let me just share my slides. I will have to replace. Okay. Right. So our next speaker of the day is Professor Mike Tranel, who is affiliated with the Newcastle University in UK. And Prof. Mike Tranel will be talking on the digital delivery for diabetes remission at scale. Basically how the direct trial, I think, right, if I'm correct, can be digitalized, right, and how it's been successful. So Prof. Mike Tranel is a clinical scientist with special interest in technology and healthcare innovation. And today, with DICER, he builds scalable digital infrastructure. Right. With that said, the stage is all yours, Prof. Tranel.
Thanks, Jing Lee.
Okay. Yep. We can see your slide.
That's great. No, thank you very much, and it's great to have the invitation to speak today. My name is Mike Trenau, and I'm a clinical scientist who's worked in obesity and diabetes for over 20 years. And then I did a strange thing of retraining to focus on digital technology. And what I'd like to do in the next 18 slides is take you a little bit along that journey and talk about why I retrained in digital and why I think it's a really important thing for us to be thinking about. My disclosures are, so I work for DASA, which is a company that builds scalable digital infrastructure. I'm also a past board member of the Novo Nordisk Foundation, and I've done paid consulting work for Abbott Nutrition and Changing Health. And much of the research that I've done over the last 20 years has been supported by Diabetes UK and the National Institute for Health Research in the UK. I'd like to talk about three things. So I'm going to start off by talking about essentially where I've seen the field grow, and Mike's given us a fantastic background on that so far. I'll give you a slightly different view on how I've seen the field of diabetes grow and why I found that so confronting. I'll then start to show you some of the data around digital technologies that we use today. And the take-home message at the very start is they work, and you should be taking them very seriously. I'm then going to talk about the future, because although digital technologies work, I think we have a lot of work to do. So although digital technologies are very powerful, I'm going to try to persuade you not to build another app, but to focus on people, not the technology. So if I start off with the science that's evolved over the last 25 years, and when I first started working in diabetes, much of our understanding was really driven by studies like UK PDS. And what this trial did is it had a look at different interventions, and it had a look at the effect of HbA1c over a number of years. Now, the things that really stand out to us here are that when you give intensive treatment to people, you get a significant improvement in HbA1c. But the thing that also stood out to me here is that when you give these fantastic interventions, they give you an improved period of glycemic control, at which point you then follow the same trajectory of worsening of diabetes control over time. So the take-home message from this study was that diabetes was a chronic progressive condition, something that we now know is not necessarily the case. But even 25 years ago, we had a look and the field was thinking very, very differently. And science has been really important in changing how we think about diabetes control. The Look Ahead study was really one of the first major intervention studies alongside the diabetes prevention study that Mike showed. And these were large-scale intervention studies that showed that you can support significant weight loss in people living with type 2 diabetes, but also that gives significant improvement in diabetes control over a long period of time. And the thing that really stood out to me here was that you can really lose very significant amounts of weight at scale. And although there's a weight regain, there's still a significant weight loss compared to the control group. Now, over time, it's unusual for a control group to lose weight, but many of the control group in Look Ahead actually started some of the interventions that were used in Look Ahead. And this is one of the foundation studies for why we start to look at lifestyle behavior change in type 2 diabetes. And it was one of the first studies to show remission rates in type 2 diabetes, with remission seen in about 20% of people. And then Mike Lean and Roy Taylor really shook our world with the concept of the direct study. And Mike's showing you this wonderful data, but it really sent a jolt through the entire field. And in my career, there's been very few studies where I've seen this, with one piece of science which really strikes a debate and changes the way that we think. So you can achieve remission of type 2 diabetes, and this is a normalization of HbA1c without diabetes medicines. And it was just a profound thing to see that the work that we'd seen for the previous 25 years to be turned on its head, that diabetes really is not a chronic progressive condition. And that's really powerful and it's potent. But this is the number that really stuck out to me. So at the point where DIRECT was published, only 4 in 5 people in the UK had access to any form of structured education about type 2 diabetes. And it became a real confrontation for me, because whilst we were doing this world-class science that was transforming disease, there was this translational gap from what we do in the laboratories into everyday clinical care. And there was a lady called Monica from Darlington, which is a town just south of where I live, who really highlighted this. She was lying in the middle of one of the MRI scanners that we used to study changes in fat deposition. And she said, "Mike, why has my doctor never told me that walking is good for my diabetes?" And that was really a challenge for me of what's the point in doing all of this science if we don't translate it into care? So on the back of that, we realized we needed to help support education at scale. So how do you take this amazing science and help people use it at scale and with equity across an entire population? And it was clear technology would be a major part in that. So on the back of that lightning bolt, I moved to the US and retrained in technology and retrained in artificial intelligence, and then came back to the UK and started to explore how we can use digital technologies. And the take home here is digital technologies work and they have equivalence to face-to-face. But what I'd like to do is try and introduce some of the subtleties that people don't pay attention to, but that I think are really important. So as you would expect, some of the first interventions to use digital were diabetes prevention programs. And in fact, the first digital program that we built that was used at scale was diabetes prevention. And this is some of the data from the NHS, the UK National Health Service digital diabetes prevention program that introduced digital. And when we first did this, and this was 6 years ago, there was a real challenge of, the conflict between face-to-face and digital. And what I'd like to propose is actually there isn't a challenge of them pushing against each other. They're just different. And the data that we have from the UK diabetes prevention program reinforces. What it shows is that digital services are taken by younger people, and they have similar effects to the face-to-face services. And I think this is really important because younger people are harder to access, so they find it more difficult. And so giving them a choice means that we relieve the pressure from face-to-face services so that they can support those people who can't access digital or don't want to access digital service. So the first point I'd like to highlight is please don't think about digital and face-to-face as different. Actually, they're part of the same journey. For some people, they have a preference for one or the other. But running studies to look at comparisons, look at differences, it isn't right. I think we should be thinking about how do we take a population of people and support them, and digital is a very important part of that. And then there was some work by Elizabeth Murray that was showing that you could provide digital education and that this had a modest effect on diabetes control. But what it was is it was scalable. So you could make digital structured education available to a population that would be unreasonable or unfeasible with a face-to-face journey. And so we then set about how do you build a population level digital education program. And so we, with NHS England, we launched NHS Healthy Living, which is an evidence-based structured digital education program, which is now free to everybody in the UK and Northern Ireland living living with type 2 diabetes, so just over 4 million people. That really began to address the problem that Monica said of, why am I not being told this information? The real challenge actually here is when you work through the nuances of how you provide digital health services, there are some very practical things that you need to build into the design. And this is a good way to visualize those. So often we think about the patient as the only is the primary objective. So how do we support patients with their education? Now, digital interventions are complex interventions, and there are 3 core things that you need to address. So not only patients, but also how do you help healthcare professionals engage and support a new way of doing things? And then how do you support system activation? So that's a demonstration of cost saving and policy alignment. And NHS Healthy Living is a good example where we've learned dynamically how you do this. So things like we needed to have reimbursement codes directly for patients to be referred to the program. There needed to be awareness campaigns for healthcare professionals. And importantly, without these additional components, digital interventions don't get used at scale. So when you're thinking about digital interventions, please don't just think about the patient component, think about the implementation of how you take a digital service and you implement it at scale. And specifically to Remission, the data is really very strong. And so this is some data that for a digital intervention that we presented at ADA last year of a digital intervention from Changing Health and Abbott Nutrition. And this is the published data that's in the public domain. So weight loss of around mean weight loss of 10 kilograms, HbA1c changes that are in line with what Mike would expect. And one of the things that was different in this study is when you started to give people individual preference. So they had a choice of 4 meal replacements, 2 meal replacements, or real food. 84% of people chose 4 meal replacements. And I think there's a deep amount of learning for us to understand how we incorporate individual preference and into diabetes remission. If calorie intake is so important and weight management, how do we give people individual preference to explore what's the right intervention for them? And the NHS in the UK has really taken the direct study and started to scale out this at a national level. And it's created the Pathways to Remission program. And this is summary data of the participants through the program so far. The weight loss is very pronounced and probably not quite as effective as some of the research studies. But the thing you can also see are the standard deviation bars. There's quite a broad range of weight loss from modest to very significant. So the take home from here is that these interventions work and can be used at scale. My encouragement is to look into the detail. And so whilst in our trials, we present the data, there's a lot for us to learn from the variation at a population level. So from the Pathways to Remission program, from those people who've finished in the most recent publication, which is at the bottom of the screen, only 55% of people completed the program. So there's a real challenge for how we manage the 45% of people who didn't. So not just optimizing the journey for that 55% of people, what happens to the 45% who will have had their medicine stopped? So we need to then re-engage them into the care pathway. But also, do they get another chance? Is it just that one opportunity that they got was the wrong time for them? At the moment, that's all you get, is you get one opportunity. So I think there's a real importance for us to understand how we engage and give people multiple opportunities, and we can also give them multiple choices of interventions for them to use. There's a clear part of medicines management and definitions, which is, although it's not quite semantics, it's a really important thing. So once you start a low energy diet, you should stop your diabetes medicines and blood pressure medicines. And what became clear was that the care teams didn't follow all of the guidance, so many people remained on metformin. And that created a problem because when they looked at the definitions of remission, people who had a normal HbA1c, 17% of those were still on metformin, which means that technically they didn't have remission. But there's also a deeper part to this, that how do we manage the people who don't achieve it? And that's the thing that I'm starting to see is once we're implementing these programs, capturing and re-engaging the people who, the 45% of people, is something that we need to think about. How do we create care pathways that do that? And although the clinical guidelines talk about the need or the importance of not having a one-size-fits-all, essentially that's what we have at the moment. We have different flavors of the same type of interventions across multiple providers. Some are digital only, some are digital and online communities, some of them are digital and face-to-face. But they follow the very same principles of direct around meal replacements. And I think there's a real need for us to understand how we can optimize that and incorporate different approaches for different people. The science in this space is really early, so please don't think I'm being critical. I'm not. I think this is a really important time for diabetes, in that we've changed how we think. Now I think we need to understand the variations that we have across a population. And so looking forward to the future, I think if I have a look over the last 10 years, I've built over 30 digital health services. And I'd like to share a thought really, which is where the future is, which is what I can see when we create these services. And if we build an app, you drop it into a care pathway and people get one chance, one opportunity. Either they engage in it or it can sometimes create a burden, another part in the care system. So I think we need to go away from thinking about just creating digital services and helicoptering them in to understand how we can start to use digital as part of a continuous care journey for individuals. And through this, we can start to use digital technologies to at a population level to understand what types of interventions and support individuals need. So how could we provide digital technologies at a population level, all the way from at risk of diabetes through to low energy diets and through to using some of the more advanced medicines like the GLP-1, GIP medicines. What we should be doing is making the journey easier. And at the moment, we've got a fragmented way of providing care, which is really about helicoptering in specific interventions, whereas we should be building those around the individual as a continuous care journey. So, and we see this over and over again, when you create what are called point solutions, so these are specific apps, digital apps, they really struggle to get scale. And they struggle to scale because the systems that procure them, that use them and deploy them, just don't have the infrastructure to do it. So starting to think more about platforms of how do you build out platforms that can help everything from diabetes prevention through to remission, through to more complicated care, so that you can have a dynamic and changing digital environment. So I think there's a really exciting time, but be really careful when you're building digital service. The world doesn't need another diabetes app. Please don't build one. What it needs is dynamic, patient-centric digital journeys. And I'd be pleased to talk about that more at another time. So in summary, I've talked about 3 different areas. The scientific data has really changed our thinking, even in my lifetime, of how we thought of diabetes being a chronic progressive condition to a condition that can support remission. Digital data is changing our thinking again. It's now thinking about how can we change this at a population level and how can we use digital technologies to access populations which are normally, which can be easily overlooked. But the future of digital isn't about point solutions. It's about how do we create a continuous care journey, and it works alongside face-to-face care. And once we start to take those types of approaches, a population-based digital approach, I think there's a really exciting future ahead. At that point, I'd like to stop and say thanks for your attention.
Thank you very much, Prof. Chanel. I was really captured listening, and I think the biggest takeaway I had from that is you've debunked the myth that I had, and in that digital delivery has equivalence to face-to-face. And I fully agree that I think the future is all about providing that continuity of care, because for the person that matters most, and that's the person living with diabetes, right? Yeah. Okay. So we'll move on to the third speaker of the day. Let me just share my slides. And it is my pleasure to introduce you to Professor Anthony Leeds, who is an adjunct professor with the IMU University of Malaysia. Prof. Leeds also holds several other honorary positions with many universities. Professor Leeds is an established clinician and researcher, and he is here today to provide us with an update on evidence for benefits in other comorbidities in diabetes remission programs. The stage is yours, Professor Leeds.
Thank you. Thank you very much indeed for giving me this opportunity, and I will now share my screen. Okay, very many thanks. First of all, I apologize for my voice, which is due to a bout of laryngitis, and it just came on yesterday. It was very inconvenient, and I do apologize for that. I don't normally sound like this. And I hope my voice will hold out for 20 minutes. What I'm going to just run through very quickly is the evidence for the use of total diet replacement programs in other comorbidities. And of course, in clinical practice, we see that there are a number of conditions which overlap with diabetes. Many of your people with diabetes will have, for example, osteoarthritis or sleep apnea. First of all, I declare one specific interest. I have a generic role in the European industry group for total diet replacement and meal replacement products in relation to ensuring standardized legislation across Europe, which is a generic role. So we're going to consider those other comorbidities, obstructive sleep apnea, which may well affect, in some of the surveys, certainly up to 80% of individuals who have diabetes. Of course, it's not an all or nothing. There are different levels of obstructive sleep apnea, and so the figures you get will be slightly vary from study to study. Osteoarthritis in the UK, with an aging population, we have an increasing number of people with osteoarthritis. And of course, osteoarthritis has the effect of reducing mobility. Therefore, people are not as active. They don't get out as much. And it's perhaps makes diabetes a little bit more difficult to manage in the clinical environment. Cardiovascular risk factors. Mike has already mentioned the huge change in hypertension that we see with the direct type of program. But also there are improvements in lipid profiles, and I'll come to this in just a moment. Inflammatory markers. There are just the beginning of a few studies in which these have been measured, but it may well be that in the future we should look much more extensively at these. And then finally, I'll consider the issue of fatty liver and then suggest some next steps. So let's start with obstructive sleep apnea. Certainly in the past, it was relatively underdiagnosed in the United Kingdom. I think it's a little bit better. And I know that, for example, in Singapore, people are really quite intense in terms of their ability to diagnose this, so it's less likely to be missed. But nevertheless, although if you look at the guidelines, weight loss is recommended as a core part of the management of obstructive sleep apnea, in actual practice, it's not done terribly effectively. Very often there's an assumption that the best way of dealing with this might be to refer the patient for bariatric surgery, but of course that's not available in the UK. Not very available in the UK. We only do about 7,000 cases per year now. And of course, drug therapies for weight reduction may well be beneficial. But we don't actually tend to use formula diet programs specifically for obstructive sleep apnea. but there's no doubt that reducing weight is beneficial. So I'm going to go back to an old trial that was started in 2007, undertaken by Stefan Rossner's group in Stockholm, in which they took men with obesity and severe or moderate sleep apnea and they chose to use a very low energy diet, so about 650 calories per day for 9 weeks. And you see the weight loss there was very, as you would expect, quite marked, down to about an 18 kilogram weight reduction. But the most important thing was that the change in the proportion of individuals in terms of who improved and who maintained or worsened their obstructive sleep apnea, you see that the majority of individuals, bottom left there, were actually improved. They encouraged those individuals to maintain their weight, and this was quite an intensive management program within the obesity unit at the Karolinska Institute. And there was a very good weight maintenance at 1 year of about 15 kilograms. 48% of them no longer required their CPAP machine. That's the machine that blows positive pressure air into the airway to hold it open in order to prevent the episodes of apnea and hypapnea that occur under untreated conditions. 10% had total remission of their obstructive sleep apnea. So there was a drift of all the individuals towards a better state. People who lost most weight or had the most severe sleep apnea benefited the most. In the same journal, there was quite a strong editorial which actually suggested that clinicians now should really take note of this and should start to apply this a little bit more aggressively. A figure that occurred in one of the papers was this comparison of the amount of weight loss with the amount of change in the apnea-hypapnea index, and giving around about a 15 kilogram weight reduction corresponding to a 20 unit reduction. Now, of course, there's huge scatter here, so there's enormous variation. And you've got to remember also that there are other factors that affect obstructive sleep apnea. It's not just the question of the level of obesity, but also the structure of the throat and the nose and the actual state of muscle as to whether the tension in muscle also is a factor. And so many patients are referred to an ENT surgeon for a review of the structure of the mouth. So many other factors, but here it's suggesting 15 kilograms weight loss will give a 20 unit reduction of the index. Now, the other interesting question is, in clinical practice, I saw a number of individuals who didn't specifically have obstructive sleep apnea, but who reported that their sleep was very much better. And I was very pleased that Sinja Torikoff's group in Copenhagen incorporated measurement of sleep using an accelerometer and also the Pittsburgh Sleep Questionnaire Index scores to assess individuals who were being prepared for another trial. This was a trial where they started by doing an 8-week low-calorie diet of about 820 calories, so that was a single arm, and then they were randomized for a 1-year weight maintenance program, which was one in which there was a comparison of exercise and no exercise, and also the use of GLP-1 agonists. This is a very interesting paper, and I do actually recommend it to you. I've given you the reference at the top there. And these slides will be provided as a PDF after the event today. After 8 weeks of the low-calorie diet, the average weight loss was 13.8 kilograms. These people were marginally obese. None of them were known to have obstructive sleep apnea. They did not have a label of obstructive sleep apnea. Sleep duration, according to the accelerometry measurements, increased by 17 minutes per night, which perhaps doesn't sound very much, but maybe it is important. And then the scores recorded on the Pittsburgh index were improved for sleep efficiency, perceived sleep quality, and disturbance. So this is providing some evidence that in people who do not have it or do not know that they have a specific sleep problem, that there is improvement of sleep. And it certainly matches up to my observation in clinical practice that losing 10 or 15 kilograms in weight actually improves sleep, but it does require more investigations. However, in the bottom point there, I've actually quoted from the paper, which says that short sleep duration or poor quality sleep was associated with weight regain after weight loss. Now, that's the result at the end of 1 year. That's a separate part of the study, but it is interesting that it is pointing to the fact that sleep is actually very important. And arising from this, although this hasn't really been followed up very intensively, it suggests that actually in clinical practice, we should, when we're talking to people about whether or not they want to lose weight and go on various programs and discussing options with them, we should also ask them about sleep. We all know that sleep duration in the populations of Western Europe has decreased quite dramatically over the last 20 or 30 or 40 years for a whole variety of reasons, including the availability of devices that catch your attention and televisions that where you might want to sit watching. I've certainly had patients who would tell me that they sit and watch more than one film in one evening, which seems to me somewhat unnecessary. But anyway, I think the key thing is that we really should talk more to people about sleep, especially if they have diabetes and especially if they have osteoarthritis, because sleep quality is impaired by pain. And people with osteoarthritis have knee pain, hip pain, and they may have pain in other joints in their shoulders and so on. And one of the problems that they describe is great difficulty with finding a comfortable position in order to get good quality sleep. So sleep quality has an effect in this group as well. I'm now going to run through 2 or 3 or 4 slides which refer to a trial of the use of total diet replacement in people, older people with knee osteoarthritis and who also had obesity in Copenhagen. It was a dietitian-managed secondary care setting. 192 people were randomized either to a total diet replacement or to a very low-calorie diet at this particular point. This is 2007. And then at the end of the 8 weeks, there was gradual reintroduction of food, so that on average they were then consuming about 1,200 calories per day. This was intensively managed face-to-face in sessions with the patient, with the people, the participants sitting around in discussion with a dietitian, in a group session, education, 17 sessions of education, very intense, but also the opportunity for one-to-one interactions. There was significant weight reduction. The figure there shows you that by 8 weeks, both interventions gave a good weight reduction of about 12 to 13 kilograms, slightly more with the very, very low energy diet. Interesting thing here, if you actually calculate the energy requirements and the expected weight reduction, what you find in this group, of whom 2/3 are women, as you know, in osteoarthritis practice, particularly knee osteoarthritis and hip osteoarthritis, women are affected more than men. So 2/3 of these people were women. And also, if you look at the studies on body composition in people with osteoarthritis, there is a reduction of lean mass. So the calculated and expected weight reduction doesn't occur because the actual energy utilization of these people is less than you would expect based on total weight. So they didn't lose quite as much as was expected. But at 8 weeks, they then had reintroduction of food, taking them down to about 1,200 calories, so that at the end, excuse me, at the end of that period, they'd achieved a very good weight loss. Now, symptom scores were undertaken using the OMERACT or ORC questionnaires, and they had a very good symptom response overall. At the end of 16 weeks, they were randomized to either a diet group, which was an attempt to try to maintain the weight using 1 meal replacement per day. And you can see that that was very successful with a maintenance of, on average, an 11 kilogram weight reduction at the end of a year. In the knee exercises group, now this was a group, this is not anaerobic exercise, this is exercises of the knee to strengthen the muscles. The design here was designed to ensure that the amount of contact time with the healthcare professional, either the physiotherapist or the dietitian, was matched in the 2 groups. And you see that in the knee exercises group, there was a good weight reduction, but it was slightly less. And there was a control group who received no intervention at all throughout the year, so they did extraordinarily well. But they did know that they were going to have an opportunity to be invited to participate in the next phase, which was a 3-year weight maintenance following this at 1 year. Numbers of dropouts were very small. I think it's interesting that, and I've spoken to a number of the participants in this trial, that they are, once they've started to lose weight, they become very enthusiastic. They begin to lose their pain after 2 or 3 or 4 weeks. They become more mobile, and they tell you in Copenhagen things like they couldn't really use their bicycle, and they were able to get on their bike again and go cycling around the city. And then also for those for whom there were grandchildren to look after, actually getting up off the floor after losing weight is very much easier than before you lose weight. So actual real life quality of life improvements. So excellent compliance and statistically significant pain reduction. Here are some of the graphs from the papers showing you the pain scores. On the left, you see the figures for 8 weeks and 16 weeks. And then on the right, you see the figures for the 16-week to 68-week period. So interestingly, the pain effect does not go away. It doesn't drift away. It stays in place. And this is really rather interesting. And the question is, what's actually happening? Well, nobody's actually absolutely sure, but it's highly likely that there is reduction of the inflammation in those tissues adjacent to the knee, which actually are signaling the pain. And that's likely to be the synovial membrane. And this is the work of one of our PhD students in Copenhagen, Robert Rees, who scanned a very difficult but highly successful process here of scanning the synovial membrane and looking to see the blood flow as a marker of inflammation. So it is highly likely that inflammation is reduced in the synovial membrane, and highly likely it's also reduced in the fat pad just under the kneecap, so that there is less signaling with pro-inflammatory signaling compounds. That is likely, but still a bit of work to do. Now, we also have a biomechanics lab in Copenhagen, and so all of these people participated in studies looking at the way in which they were walking. And it is interesting that people walk in different ways and respond differently to weight loss. But overall, on average, a 15 kilogram weight loss gave a 33 kilogram reduction in peak joint load. As you know, every time you take a step, you're putting forces on your knee and your hips and right up through your spine, of course. But these actual sophisticated measurements showed that there was a reduction in the peak joint load of 2.2 kilograms for every 1 kilogram weight loss. So we can summarize the position on osteoarthritis very briefly here. You will get this slide later on. But in addition to the things that I've mentioned about the pain reduction persisting, we've also got evidence of reduction of inflammatory markers. And also one other thing to remember about total diet replacements, and this hasn't been looked at very much, is that by providing all the daily requirements of micronutrients in a bioavailable form, there may be some changes in nutritional status. Now, half of these people, older Danes with knee osteoarthritis, were vitamin D deficient. We also looked at bone mineral loss, and there is a published paper which shows you that by giving vitamin D3 within the products that we use for the weight loss program, the numbers of them who had deficiency was reduced by the end of the 16 weeks. And then in those who followed the diet program was also reduced at 1 year. Now, this is an important thing to think about. There is always bone mineral loss when there's weight loss, but the bone mineral loss in these people was less than was expected based on the weight change. So by improving vitamin D status, there was an improvement there. Blood pressure reduction on average was about 10 millimeters of mercury, and that was maintained if weight was maintained. And of course, that then has an effect on calculated cardiovascular risk. So this is actually really interesting, very exciting. And the position with this now is that there has been a study in Edinburgh and Leeds, led by Hamish Simpson in Edinburgh, to look at a package of care delivered within a normal NHS environment, a package of care of analgesia, optimization, orthotics, the inserts that go into the shoe to readjust the way in which people walk, knee exercises, and weight loss with total diet replacement. And that has shown that this is a viable intervention that could be applied in clinical practice. So the next step is to see if it's possible to actually make this available, especially as we have hundreds of thousands of people waiting for surgery in the United Kingdom. I should say also that those who go through that medical program prior to surgery, 1 in 10 of them choose not to go forward for surgery because they are so improved in terms of symptoms. So that's good up to a point, but there's more work to do. Mike Lean did mention the improvement in blood pressure, which is a quite dramatic change, which does mean you have to be very careful when guiding people through these programs to ensure that you're monitoring blood pressure and reducing or stopping the antihypertensives, because it is possible that you might have episodes of postural hypertension, as Mike mentioned. Taking some of that information, the cardiologists at Copenhagen undertook a study in women with who'd had a coronary event, an acute coronary event, and who had either stents or other interventions. And they were passed into a randomized trial of either aerobic training or the low energy diet program. They did the low energy diet program, and then the aerobic training was added to that. So everybody effectively eventually was doing the aerobic training. There were 70 of them. They've divided about 35 in each group. Weight changes at 12 weeks, 9.9 kilograms weight reduction, and at 1 year, 7.2 kilograms. Now, there was also some studies of myocardial function, including coronary flow reserve, and the coronary flow reserve was improved at the end of the weight loss period, but by the end of the year, there was no significant difference between the two groups. And this is quite possibly because the weights actually drifted up a little bit, and so they were in positive energy balance, and the whatever the mechanism is whereby weight reduction would improve coronary flow reserve, it obviously didn't apply by the end of 1 year. Now, clearly, there's more to do here, especially as you see at the bottom there, you get metabolic benefits. The lipid profiles, the LDL particle size and the pattern of LDL particles changes to be less atherogenic. There's measurable cardiovascular fitness improvement, and the lean losses which occurred in this study were really very low, so nothing to worry about there. So this is interesting and exciting, but there's much more to do. And unfortunately, when this was published, it wasn't followed up with further studies. I mentioned inflammatory markers, and Sinitorikov, again at the University of Copenhagen, undertook a study in which, excuse me, 43 people who were labeled as healthy obese with no specific conditions, followed an 800-calorie diet, a total diet replacement, achieved 12% weight loss, and were then randomized to either exercise, no exercise, delivery of GLP-1 agonists or no, or a placebo. Bloods were collected at the points you see here. Bottom left panel, you see the BMI changes. The team, and this was done at the Max Planck Institute in Germany, chose 400 proteins were measured in the blood samples. 10 out of 400 were proteins that marked inflammation. 4 out of 10 marked a pro-insulin resistance panel. And they divided the subjects into those who were either had a high metabolic burden based on the actual values obtained, or a low metabolic burden. And you see in the left-hand figure there, you see the effect of weight reduction and the fact that they were able to maintain that weight reduction very well through to the end of the year. The inflammation panel came down in both groups, but interestingly, continued to go down over the full year in the group that had the high metabolic burden, and that's really interesting. And then the pro-insulin resistance panel, most of the benefits were seen in the first 8 weeks of the weight reduction. And one of the comments that the team made was that really these results show that even if people do not have a label of problems that are weight related or energy intake related, probably there are things there. This is a very interesting paper, and I do recommend it to you. And again, sadly, this has not yet been followed up, but I hope it will be in the near future. In terms of other conditions, you will recall that Mike Lean mentioned that Roy Taylor studied a subset of individuals to look at liver fat and pancreatic fat. And in the left-hand side there, I've shown you one image that shows that in this particular individual, the fat content of the liver was 30.4% at baseline and 1.3% post-weight loss. And then the pancreatic fat was 8.9% and reduced down to 7.5%. The message on this slide is that the maintenance of remission was associated with more effective weight maintenance and more effective maintenance of liver lipid reduction. And responders lost more weight and regained less weight, possibly reflecting tighter energy intake control during maintenance, which I think is the practical point that comes out of it. But I've put this one up here as a reminder that we have a big problem in clinical practice with fatty liver and the consequences of fatty liver, fatty fibrosis, going on ultimately to cirrhosis, and indeed but there are now relatively young people who actually require liver transplants because they've been picked up very late in the disease process. And I think that one other thing we need to look at when we're thinking about diabetes remission programs is the state of the liver, and to consider whether or not we could be doing something to monitor liver function while doing all the other things. So the next steps, I think, ideally, I know it's difficult and I know it costs money and it's difficult to set up. We should collect data on the other comorbidities in any national rollout of a pathway to remission. We should ideally write into the protocols that data will be collected. And I think I might have managed to persuade a colleague to put some collection of information about sleep into one of the protocols in one of the health boards in Scotland. Obstructive sleep apnea are likely to occur. It would be good to have some accelerometry data and to know exactly what's happening. Blood pressure obviously is recorded and responds very well. We need to think about fatty liver and fibrosis. Cardiovascular risk factors, of course, we should be thinking about. It is interesting that in cardiological practice, weight reduction doesn't seem to be emphasized very much. If you look at guidelines for Europe, there's a great deal of discussion about intensive exercise programs in secondary prevention. Weight reduction is not really emphasized perhaps as much as it should be. And then I think we should focus more on inflammatory markers. So to summarize, the amounts of weight loss achieved in direct can also deliver, in other words, 10 to 15 kilograms, big improvements in obstructive sleep apnea, and I'm sure in practice that they actually do that. Improvement of sleep, even where there's no specific sleep disorder, and then reduction of pain in those who have osteoarthritis, benefits in terms of cardiovascular risk, well, that is known, and Mike's comment right at the very end there about severe adverse events at the 5-year point, I think is an indication that this is probably very important. And then weight loss can profoundly affect inflammatory markers, and so we should be thinking about this, and also in relation to other inflammatory disease. So thank you very much. I will stop at that point.
Thank you, Prof. Leeds. It's good to look at evidence to remind us again that obesity really is the mother of all diseases, and with weight loss, we can see a lot of benefits just beyond just managing diabetes, including quality, I think, of life, right? So now it's my pleasure to introduce the final speaker of the day, and she's none other than Professor Winnie Chee. Let me just pull up my slides, yeah. Prof. Winnie Chee is affiliated with the IMU University in Malaysia. She's a dietitian and also Pro-Vice Chancellor for our university. And she has more than 30 years of leading the dietetics profession in Malaysia and Asia. So today she will share with us an update on liquid meal replacements for diabetes. Okay, Prof. Winnie, the stage is all yours.
Oh, thank you very much, Shing Li, and good afternoon to everyone. Good evening. I know some of you, it's almost your dinner time, so I'll try and make this quick. Let me just share my screen here. And can you see my screen now?
Yes.
Okay, thank you, Shing Li. Okay, well, I think we've heard a lot today about remission, but in the context of most of us here who are dietitians, I'm not sure if any of you have really done remission with your patients yet. As far as I know, I don't think any clinics in Malaysia is doing it. I know some clinics in Singapore may be doing it if our colleagues in Singapore are still with us here. But what I intend to do today is basically talk about, for most of us who are using liquid diets more for meal replacements, what is the current status, and is it still relevant? And what about in light of a new, medical treatment that's coming up in diabetes currently? So here are my disclosures. I've received grant from Abbott Nutrition, and also Kotra Pharma, and I've received honorarium speaking from various companies. So as I said earlier, I'll try in the next 15 minutes or so just to discuss the role of meal replacement as part of a comprehensive lifestyle intervention and show some of the latest evidence that's available. We'll talk a little about dietary patterns, because I think I see that Professor Lin talked about dietary patterns earlier, and there's some questions about it. And then I think some of us who are working, especially in private sector, perhaps you'll be coming across patients who are using the latest trends in medical treatment, which is GLP-1 medications. And in that context, do you think the use of meal replacement is still, can we still prescribe meal replacements? So I think for all of us here who are from Malaysia, or if you're not from Malaysia, this is the situation of our food environment and the situation of our patients. And that is why obesity is still very high in Malaysia. Diabetes is still very high, hypertension, hyperlipidemia. Nothing has changed. If you look, well, some improvements, but not for some of the non-communicable diseases in our latest National Health Morbidity Survey. So, but we all know that medical nutrition therapy is very important. We all know that we need to target people to lose weight. You've heard from the 3 lectures today how important that is and how that can actually help a lot in reducing the comorbidities and prolonging life for our patients. Now, in light of all this, to change the diet and to suddenly swap to eating healthy is not easy. And these are all the meals and dietary patterns that I think currently we hear our patients are asking us, should I follow it? Or we ourselves as dietitians is wondering, do this really work? How do we navigate across all these complexity of what we can do with the diet in terms of controlling our weight, especially in people with diabetes. So what I'm going to focus on for the next few slides is more about meal replacement, and then we'll come back and revisit this again. Now, I think the use of formula diets is not new to all of us, right? If for those of you who work in the bariatric surgery space, you use it anyway. You use VLCD a lot in order to promote the weight loss and to make better perioperative outcomes in patients with bariatric surgery. What you're hearing now is that that sort of approach can actually be used for people with diabetes and create remission. For the rest of us who may not work in bariatric surgery, you're probably using meal replacement for weight loss and for glycemic control in patients with diabetes. And then again, when the patients get hospitalized, a lot of us use formula diets for nutrition support in malnourished patients. So it's not something new for us. But I guess here you hear a lot about total diet replacement and you hear a lot about meal replacements. So is there a difference? I learned recently in Australia, there is a difference. So formulations that are meant for meal replacement or meant for total diet replacements are quite different. So if you're doing something that's liquid diet that's meant for total diet replacement, in other words, it replaces the whole diet because of remission, because you're facilitating optimal weight loss, it has to be nutritionally balanced because that's all that the patients will be taking. And these are usually based around formula foods. So they are usually liquid, but sometimes they can also be bars and other forms of the replacement, the formulas. But if you're using it as a meal replacement, which most of us probably are doing that and supporting our patients to do that, it's actually a replacement for 1 or more meals of the day. And they're usually used alongside conventional food. So it's not all that you take is the replacement, but you do eat foods as well. However, a lot of the current meal replacement content that we see that's available, at least in Malaysia, will have certain formulations. It will have certain ingredients in it that will help, for example, with diabetes control, or it will help with satiety. It will contain, or some of it even can be bought online through Shopee or through Lazada, and it's imported from overseas. So all of these is the plethora of meal replacements that our patients have that option of doing. Now, we've also heard that it's very important for that lifestyle intervention work in diabetes prevention as well as management. I think Professor Lin has talked a lot about, and you've heard about the look ahead, the direct trial, of course, and also there's the preview trial as well, and the DPP, which I think about 20 years ago when the diabetes prevention program came up, I think that was a big boost for lifestyle intervention. And you notice that in all of these big trials, not all of it, except for the DPP, which focuses more on calorie and low fat, the rest of the other trials are using either total diet replacement or meal replacements. And if you look at recommendations, it's all there. Malaysian CPG guidelines, the American guidelines are all do mention the role of the meal replacements in specifically effective in either lowering blood sugar control, lipid profile, blood pressure, or body weight. Now, so one of the literature, if you look at it, as to what actually is it really effective in terms of knee replacement? And this was a systematic review and meta-analysis that was conducted by, I think if you look at the names here, some of you who are working in the area of diabetes and obesity, you see some very famous name here. And they did a systematic review because they wanted to look at whether for the European guidelines, that doesn't mention much about knee replacement, what is it that's currently available in terms of the evidence. So I encourage you to read this paper. It's in Diabetes Care. It's free. You can download it. It's open access, where they look at the effect of liquid knee replacement on cardiometabolic risk factors in overweight and obese individuals with type 2 diabetes, which is basically 80% of the patients that we see every day in our clinic. Now, let me just walk you through a little bit about the various studies, the studies that they included in this systematic review, because they had very stringent criteria following well-established guidelines. So there are at least thousands of studies out there, but eventually when they review all these studies, there were only 9 studies that they included that met the quality criteria for them to do this systematic review. So in total, there were only 9 trials that was included that was of high quality, which looked at following up patients up to 6 months with the use of knee replacement. 4 of it is actually in Asia. Out of the 4, I'm happy to report that 1 of it is the study that we did in Malaysia. And then most of the patients are around 55 years old to 60, which is also the demographics that we have in Malaysia. Of our population with diabetes that we see most in our clinic, almost equal number of male and female. BMI is around 30, very similar to what we see in clinic. HbA1c of about 7.6%. And if you look at the intervention formulas that are used, this is across the different types of formula product that's available. Some of it are available in Malaysia. And the total calorie intake of the intervention group is around 1,500 calories. And the macronutrient composition is around 48-50% carbohydrate, 30% fat, and 20% proteins. If you look at the comparison group, you will see that the comparison, what do they compare the meal replacement with? It's with either using food exchange system or low-calorie, self-selected foods, diet book, and so on. Matching the calories of also 1,500 calories using, just using foods, macronutrient distribution almost the same, but slightly lower in fat and proteins. And in all of these 9 studies, the dropout rate is also quite low. So what does all these 9 studies systematic analysis show? They show that, first of all, meal replacement was very effective for reducing adiposity. And you can see that the most significant was for body weight reduction, BMI reduction, body fat percentage reduction, and waist circumference reduction. The other thing that all these 9 studies showed was it also helped with glycemic control. You can see A1C going down, fasting glucose significantly lower, fasting insulin significantly lower. And the last part is that it also helped to reduce blood pressure, but it did nothing in terms of blood lipids. So 9 of these studies did not show any improvement in terms of LDL cholesterol, HDL cholesterol, or triglycerides. So the conclusion from the systematic review was that liquid meal replacement in weight loss diet lead to modest reduction in those parameters, but they say that it is of perhaps marginal clinical significance, and probably more trials are needed to see, how certain. Some of these trials are rather, there's only 9 trials here. However, it was effective. It does lead to reductions in that short term of a maximum of 6 months. So I'd just like to take you then to a recent study that we did in Malaysia, and this is together with scientists from various countries, including from Thailand, and some patients from Thailand as well, and together with scientists from the industry, which is Abbott Nutrition, where we looked into a trial of about 235 patients from both Malaysia and Thailand. And we randomized them into receiving either 1 or 2 meal replacement and compare to, standard of care. And here you can see that the data collection was across baseline, 45 days, and also 3 months down the road. Now, the results that we saw was actually quite very interesting, because we saw significant reduction in HbA1c in these patients. Fasting blood glucose profile reduced as well. And if you calculate the HOMA beta, which is the beta cell function, you can see that those that lost the weight with the use of the meal replacement, which is here, in this case, diabetes specific, you see an improvement in the beta cell function versus those who were on standard control diet. Then in terms of body weight, fat mass, and also visceral adipose tissue, there's also significant reduction in all these parameters, and also a significant improvement in fat-free mass as well. So this includes the muscle mass of the patients who were taking the meal replacement for their diabetes control and weight loss journey. In terms of blood pressure, no surprise there. You can see that reduction in blood pressure is significant. But what I think is very interesting is that the participants who had a higher BMI, who were taking more of the 2 meal replacement a day, we did see a change in the triglyceride level. So there was a significant reduction in triglycerides. And there's also a significant reduction in terms of total cholesterol HDL ratio. So I think this is also showing that with the 3-month study that we did amongst patients in Malaysia and Thailand, the meal replacement seems to have cardiometabolic benefits. Now, a couple of years back, we did the study called the TDNE, where we did similar structured lifestyle intervention, but we followed them up for 12 months. So when we stopped the intervention at 6 months, the patients were followed up for another 12 months. And we saw that sustained weight loss and sustained HbA1c reduction, as well as reduction in terms of medication, and the proportion of patients whose A1C remained below 6.5% after the intervention was high. And this was particularly seen in patients who were given motivational interviewing kind of consultation. So these patients were more motivated, they were sticking to their diets, they learned how to eat healthy, and they were losing weight continuously. They regained some weight, as you would in any weight loss intervention, but the weight regain was much lower compared to those who were not motivated in following the diet. So I guess here, dietitians, I think what we should be aiming for is, we know that the short-term intervention works. Now, what about the long-term intervention? And that is something that we really need to consider when we're talking to our patients. These are all the different types of diets that our patients tell us they'll probably be following, like keto diets, for example, which we know is nutritionally not balanced. There's also the science behind not eating, intermittent fasting, or time-restricted diet. And then there are also healthier diets like the plant-based diets, which is now getting very popular. Our conventional low-fat diet, the Mediterranean diet, I think, which you've probably heard is the healthiest diet pattern in the world, and the DASH diet. Now, I know, as what Prof. Lin mentioned earlier, that some of these diets are not easy to follow, right? But if you look into the evidence as to what is the sort of diet that will actually be important and is able to be dietary patterns that's more sustainable in the long term for weight maintenance and cardiovascular benefits. And this publication comes out where the Mediterranean diet is touted to be one of the best diets to follow if our intention is to help patients to sustain the weight loss that they've already achieved using meal replacement, for example, and the cardiovascular benefits in the long term. So this systematic review seems to suggest that the Mediterranean diet confers this kind of benefit. So is Mediterranean diet a traditional diet? Yes, if you're living in the Mediterranean countries, but it's not traditional if you're living in Malaysia. However, if you look into what Malaysian traditional diet says, and this is our food pyramid recommendation, you see some similarities there. If you look at the Mediterranean diet, there's a lot of emphasis on fruits and vegetables and whole grains. This is the same recommendation that Malaysian Dietary Guidelines is telling. There's a lot more emphasis on fish, and also a lot more emphasis on, reducing of red meats, for example, and also drinking water and staying active. So some of these components are actually also what is recommended by the Malaysian dietary guidelines. Perhaps the difference would be in terms of the portion size that's being recommended. So we know that it's a huge challenge for Malaysians to even follow the Malaysian dietary guideline portion sizes of eating 5 to, at least more than 5 servings of fruits and vegetables a day. 95% of us don't follow that. Whole grains is completely missing in most of our diets. But if we really do want to get our patients who's lost weight, that you need to now transition into a healthier dietary pattern, then we should be telling our patients to, have components of that Mediterranean diet of eating more fruits and vegetables into your diet, having more fish, healthier oils, not high-fat diets, but lower-fat diets using healthier oils, nuts, incorporating some nuts and monounsaturated fat into the diet. And of course, we have this huge problem with sugar intake in our population, which we should completely get patients to at least avoid foods that are high in sugar content. So I think this is the sort of traditional diet, if you like, that we should be advising our patients to take. Now, I'm then just going to move on now to talk about what happens if our patient is on GLP-1 medication. So I tried to look into the studies. There aren't many studies available. However, I just like to pick up a few. So there's one studies that looked at weight maintenance and whether additional weight loss, if you were to add liraglutide, after a patient has lost weight. Patients have lost weight on meal replacement. This is called a scale maintenance randomized study. So they got patients to lose weight using meal replacement, and then after that, maintain that weight loss and notice if there's additional weight loss if patients were then given liraglutide. And here they saw that 6% weight reduction was achieved with the meal replacement was better maintained or enhanced with liraglutide compared to placebo. And this is quite a long study, up to almost a year. There's also currently an interesting study that's going on in the UK, which is looking at addition of very low-calorie diet, so VLCD diet. I think in this study, they use OptiFast in patients that are using semaglutide with type 2 diabetes. And the largest reduction was seen in patients who were using VLCD with semaglutide as compared to semaglutide alone. So it looks like if we use meal replacement for for patients who are using GLP-1 receptor agonists, it may actually confer some benefits. So this is a retrospective review very recently published. They looked at 7 patients. This is not a study, but this is a real world data. And you notice here that when they followed up patients up to 24 months, the patients who took GLP-1 receptor agonist along with meal replacement seem to be able to sustain a continuous weight loss over 24 months. So the conclusion that by this retrospective review is that a combined approach might enhance weight loss effectiveness with potential impact on long-term adherence for both modalities. Now, I have seen patients, I do consult patients who are on GLP-1 RA agonists, and I think, Jingli, you yourself as well. And we know that for some of these patients, they do experience side effects such as nausea, vomiting, loss of appetite. And I've got patients who sometimes are quite at a loss as to what can they eat. And I guess this is where meal replacement can be a nutritionally balanced product that perhaps if they can afford it, they can consider adding into their diets so that, it helps also to ensure that they get the nutrients needed because they would have loss of appetite and sometimes they just skip meals or they don't eat properly. So I think I've come to the end, Jingli. So this is basically the summary is that as it stands today, liquid meal replacement is an important, it can be considered as a part of your dietary intervention for weight loss diets. It can lead to, modest reductions in adiposity, glucose control, and cardiometabolic benefits as compared to using traditional low-calorie weight loss, particularly if our patients have great difficulty selecting healthy foods or have great difficulty, controlling their diets. Then the meal replacement for most of my patients, they find that it is a simple, it's an easy way for them to do. of course, bearing in mind that they should be able to afford the meal replacement as well. Now, for long-term weight maintenance, I think the current evidence seems to tell us that we need to transition them to a healthier dietary pattern. But don't forget, exercise is very important, behavior therapy, motivation, social support, and good counseling skills is very important. And as for patients who are taking GLP-1 receptor agonists, there is some evidence to show that if your patients are willing to take meal replacement to help them on that weight loss journey, it is possible, but we probably need to see more studies to know what the other additional benefits are. Okay, I think that's all of my sharing today. Thank you very much.
Thank you, Prof. Winnie. Indeed, very, very holistic view on diets for weight loss, not just about energy restriction. We're talking about diet quality, and it'll be exciting to see how, whether or not there's a role that diet and, you know, the medication for weight loss now can play. I'm happy now to come to the last final activity of the webinar, and that's the interesting part, the question and answer. So what we'll be doing is we will be addressing the questions in a forum discussion manner. And may I request the speakers to just turn on your cameras. And I'm just going to take a look at the questions that are up there. We won't be able to address the questions specifically, but I think looking at the questions on the question and answer feature, I think there are two themes with the questions. The questions surround one, the debate around the diet composition. So with weight loss, we know energy restriction is needed, but there are several questions on whether composition of the diet matters, macronutrient composition perhaps, or what about the use of processed foods, or what about the exclusion of certain food groups, like just focusing on meats or things like that. So I open it to anyone. Maybe Prof. Winnie, you can start first. What is your take on that?
Okay, I think as a dietitian, and I think many of us here would agree, whatever diets that you think is popular, just ensure we have to really be sure that it has to be nutritionally balanced and complete. That's very important. And secondly, it's about adherence. You know, someone can go on a keto diet, you'll never be able to adhere it for life, right? So a lot of my patients, they go on some of these fad diets and then they end up, they just, socially, it's restrictive. So I think adherence is also very important to consider.
Yeah, okay. What about yourself, Prof. Lin? What is your take on, you've done remission studies. It's about energy restriction. What is your take on the diet composition then? Okay, you're muted. You're muted.
Okay. Dr. Winnie has also pointed out, and I think very, very clearly, that for a long-term weight loss maintenance, the diet program has to be something which people can fit into their normal lives, and that means fitting into their normal family lives, their domestic lives, their work lives, occupation. It must fit in with their interests and their surroundings. So from my perspective, I don't think there is value in what you call fad diets. And basically we need to to negotiate and navigate a way through the food environment that people are actually living in. Now, that means, and we've, of course, many of us have done extensive research into some of these diets which are popular, and the one which everybody still is talking about in some areas is the keto diet or low carb diets. And these diets simply are unsustainable. And we've also shown that they can be very seriously deficient in some micronutrients, thiamine in particular. So these are not desirable for long-term use. One approach which I found helpful, and I think many people find helpful, is to use what is sometimes called intermittent fasting or time-restricted eating. And that really simply means that it's a discipline. It's introducing discipline into people's lives. Which is possibly the most important element, however it's done. If you follow a restrictive diet, that is a discipline, but it's one which is not sustainable and probably not physiological. The time-restricted eating or intermittent fasting, I think, is physiologically quite normal for human beings. And I think during most of our evolution, we didn't have large amounts of food every day. And we probably did have days when there was very little food. So emulating that, and that was at a time when there was no weight gain, no obesity, no type 2 diabetes. So emulating that with days, a little bit like religious fasting, when you may say 1 day a week we're going to, have very little food. To do that on a systematic way, a disciplined way, is a way of doing it, and it's to some extent a little bit like using a meal replacement, to say, right, on either on this day I shall use only meal replacements for 1 day a week, 2 days a week, or you say, right, I'm going to use meal replacements for my evening meal or for my midday meal as a discipline. So I think what I would get to is it needs to be a personal discipline, something that individuals can sign up to agree to stick with. And for me, the intermittent fasting or time-restricted eating is actually quite a physiologically acceptable discipline.
So we should take an individualized approach, right? There is no one-size-fits-all composition. Prof. Leeds, do you have anything to add or?
No, that was all fine. I've just been reading other questions that have appeared.
Yeah.
Sorry.
Yeah.
And it's up to you to decide which ones you want to comment.
Yeah.
Which one?
Yeah. So that was the diet question. There was one that was quite interesting. It talked about the use of processed foods and weight loss. And do we have data on that, or? And I'm asking because I don't think I've looked into the data on that.
Well, formula diets are processed foods. That's what a formula diet is.
So are formula diets evil then?
I don't think we should. I think that would take us into a whole discussion about ultra-processed food. So let's not go there. We don't have the time for it anyway. So I think what's important here is, again, back to, eating whole grains, fruits, vegetable. Some of these foods you need to process, otherwise it will be poison to us, right? So I think it's not about processing. It's about getting, whole foods. Even that word is a bit different, it can be taken differently, but basically eat a normal diet that you would normally eat and ensure that you've got the right components in it, and don't eat food that's going to not be healthy for us.
Yeah. So just like looking at food as a carrier of nutrients as well, rather than just energy alone, right? So if the processed food has got nutrients added into it, that's better than processed foods that has nutrients stripped away from it. And we pick foods, we pick it based on the nutrition quality as well. Okay. Now, we have very little time left, so I want to address the second theme, and I think what's coming out in the questions is the equitable access to care, to treatment, and also to then sustenance of weight loss, after weight loss, to especially people who are low resourced, or low income people. What's your take? Maybe Prof. Turnell, does the digitalization process help this equitable access? What's your take on that?
In short, yes. So what we see is that digital increases equity of access. So it's no longer correct to think about what we talk about, a digital divide of the haves and have-nots. And I think the data that we've seen nationally shows that. The difficult thing is that people from a lower socioeconomic status tend not to be able to afford to eat well. And that's the conundrum. It's not that they can't change their behavior, it's that they can't afford to. So there's a deeper economic question there of, can they afford meal replacement? Should we be subsidizing meal replacement? So digital is really useful as a tool to access groups that are easily overlooked. But it doesn't overcome the economic limitations that come with food choice, and also not just food, but also exercise as well. So physical activity and exercise are linked into that too. So you can reach these people. I think there's a real piece of work for us to do to understand at a population level, should we be paying for meal replacements? In some of the groups, one of the reasons they choose meal replacements is because it's cheaper than choosing real foods.
Well, probably that's true. Might be true in Malaysia. If you buy a pack of
I don't think that's true at all. No, not at all true. I'm sorry, disagree with that. The cheap food is the food which helps you lose weight.
Right. Well, it is true, probably, that in Malaysia, some of the considered healthier foods are more expensive, and one of the reasons being that there's less demand for it as well. So it's economics of scale.
I think the foods which are marketed as being healthy, and you're using the word a great deal, are not actually healthy at all and not good for health, many of them.
And what I mean, I suppose, are things like brown rice versus white rice in Malaysia, or homemade bread. They tend
Yeah,
to
that's a
be more
good
expensive.
example.
Yeah.
Why? We don't know why.
Because not many people buy it, that's why.
But it's cheaper to produce. It's cheaper to produce. It's more nutritious.
Yeah.
It's just that the marketing of white rice has become fashionable.
And I think with some of my patients, it's a question of taste. So I think it's very important that we introduce healthy foods from young. So when as a child, you get used to eating this kind of foods, and not when you're already like 60 years old, then you find that it's very difficult for you to change your eating habits.
So leaning towards the eating habits, there's a question again about sustainability in low income, about the sustainability of the use of meal replacements. Now, in a lot of these studies, what happens is that the patients are on a total diet replacement, and then we have a slow food reintroduction process, right? For weight maintenance. Can maybe Prof. Lin or Prof. Leeds just talk a little bit more about how maybe if dietitians in Malaysia want to reintroduce the food, how do they do that? Or
well, I'm sure we should ask Winnie about that. Dr. Chu
Okay. Yeah.
Well, I think I do have, just to share an experience. So we had a patient recently, and he can't afford to buy meal replacements that are, the more expensive ones, because they come with clinical trials and all that. So what he did was he went online and he looked for, there's lots of meal replacement products out there right now, and he chose the one that he could afford. So I said, let's take a look at what's the nutrient content, and it's not too bad. So it does help him to be able to replace his meals, but he does feel hungry. So we then talked about how would you manage that hunger. So then he's able to lose, and he's lost 10 kilograms using a meal replacement that he can afford, that he bought online for him, based on his ability to buy. So he had great difficulty choosing foods at his workplace, because there's really most of the foods that he has around his surroundings are not suitable. So this was the initiative that he took on himself. So that also helped me to learn that it is possible, and there are a lot more products than we know. So, but it's very important that we teach the patient, and we ourselves as dietitians know how to evaluate those meal replacements to ensure that it doesn't contain anything that may be detrimental or non-evidence-based, that they don't put any ingredient in there that could compromise the patient's health.
Thank you. I think that's very useful insight into perhaps how can help.
Yeah, now we've got products from Japan, from Korea, right? That may be suitable and more affordable. So it all depends on what the patients can do. So I think we shouldn't just say that it has to be only the expensive ones that work.
Yeah, so just sitting down, listening, I think really understanding the patient's food environment, what they're used to, and then just titrating.
Yeah.
Okay, the questions are coming hard and fast now, towards the last 1 minute. Now, I don't think we can answer all. There is one that looks at if they are consuming very little calories, how do we make sure they meet their nutrient needs? Do they take multivitamin supplements? What do they do? Yeah, that was the one. Should they take multivitamin supplements?
Prof. Lin, do people in the direct trial take multivites?
No, they didn't. In a research trial of this kind, the diet program was designed by dietitians to be complete for all the micronutrients. And we can do that with many, many different diets. The problem is that when people are self-directed, and quite often people who are seriously overweight do have unbalanced diets, which may be already deficient in some nutrients, because they have stereotypic or restricted food preferences. So there certainly are some, and we know this, there are many micronutrients which are borderline or insufficient in people with obesity. So if they lose weight, they can then become deficient if they follow an unbalanced diet. So I think the important thing is to follow a diet program which has been designed by dietitians to be complete for the micronutrients. And if there's any doubt about that, taking multivitamin preparations is not harmful. Don't take the high dose or unusual dosage of multivitamins. Just take normal physiological doses.
Yeah. Prof. Leeds, you want to add something?
If I could just comment that certainly across Europe, and I know that in other countries as well, and in other parts of the world, Australia, New Zealand, and so on, the composition of meal replacements and total diet replacements are defined within legislation. So you can be sure that those products actually do provide all that's needed, and any supplementation is not necessary. Also, the compounds that are put in are actually bioavailable, so it isn't just the total amount, but they actually get absorbed. And as I mentioned, vitamin D3 is absorbed and corrected the deficiency in some of those older people in Copenhagen. It would be nice to have more studies on the effective nutritional status. I've been worried about magnesium for some time, but we haven't actually got around to doing a study yet.
Okay, thank you very much. The time now is 6:01 p.m. and I'm very conscious that we should end on time. Thank you to the participants for your questions. Thank you for staying on. We've got a quite good number that stayed on with us for 2 hours. And thank you to our speakers. Very, very good sharing. I hope we can invite you back again next year. Yeah. And for the final housekeeping announcement, do remember to scan this feedback, this QR code, give your feedback so that we can then register you for your CPD points. All right. So thank you all. And a good evening to people in Asia and good lunchtime to those from the UK part.
Thank you very much, Prof. Lin.
Thank
Prof.
you.
Daniel, Dr. Leeds.
Thank you.
See you again.
Yes.
Bye-bye.
Thank you. Bye-bye.
Bye-bye.